Hello everyone, welcome back to Stud Eye. Today we are going to discuss about a topic that is very important in optometry, which is tonometry. In this video we are going to discuss that what actually the tonometry is, what are the techniques that we are using in this, and what are the types of tonometers and the importance of tonometer in the optometry. So let's move on. So first of all, we should know that what actually the tonometry is. Here you should know that metry means measurement. So you are measuring anything, and tono means that you are measuring the pressure. So tono means pressure and metry means measurement. So here the tonometry is the measurement of the pressure of the eye, right? The other name of the pressure is intraocular pressure, which means the pressure of the eye. So in this technique you measure the pressure of the or pressure inside the eye. So this is a procedure. Tonometry is a procedure, and tonometer is actually the instrument which we use to measure the intraocular pressure. So the technique is tonometry and the instrument which we are using for the measurement is a tonometer. So here you should know, before going into the tonometry and details, we should know that what actually the intraocular pressure is, right? So I have already told you that it is a pressure which is inside the eye. So the pressure is, you can say that it is the pressure which is the balance between the rate of aqueous production and its outflow. So as we all know that there is a liquid inside the eye in the interior segment which is known as the aqueous humor. It is produced and is also drained out from the eye. So anything that is produced in the eye which is aqueous humor, it is also have to be drained out, right? So this aqueous humor is produced in the posterior chamber of anterior segment, and it then moves towards the anterior chamber. It nourishes the cornea and then it drains out through these angles. These are the angles, right? So here from these anterior chamber angles it drains out from the eye, or it moves outside. So what happens over here, that the balance between the production which is from the posterior chamber to the rate of aqueous outflow, so it is actually जितना aqueous produce हो रहा है और जितना हमारे पास aqueous remove हो रहा है eye से, that balance is actually the intraocular pressure, right? So actually if I can give you an example regarding this, you all know that when we on the tap, so when the tap water is running through a pipe, it continuously moves, right? So you can say the tap is actually the production of the water center. So from the tap the water is actually producing, and from the end of the water pipe the water is actually draining out. So you can assume that same, the eye is a water pipe and the tap is the production of the posterior chamber from where the anti-aqueous humor is actually produced, and the angle is the water pipe's end. So here if you all know that if you will close the tap end, right, water pipes end, अगर आप पाइप का एंड कर जो है उसको बंद कर दें, so what will happen, because of the continuous production of the water from the tap will actually lead to the bursting of the water pipe will burst out because of the continuous production of the water, but the water cannot move out from that pipe. So the same is the case over here. The pressure will be so much that I will actually burst out if there will be no drainage of the aqueous. So therefore intraocular pressure is actually the balance. जितना produce हो रहा है उतना ही हमारे पास release हो रहा है aqueous. So that balance can be known as the intraocular pressure, right? The pressure which is exerting on the eye. And then it can also be related to the resistance in the trabeculum or the episcleral venous pressure. So you all know that from the angles, the structure of the angles are trabecular meshwork, scleral spurs, Schlemm canal, and episcleral venous canals, episcleral canals. So these are the structure by which the aqueous drains out. So in those structure the resistance, right, can be related to the intraocular pressure. If the resistance is more, the pressure is high, because when the resistance is more, there is a lot of resistance in the trabeculum that water cannot move out of the trabeculum. So what will happen, the eye, there will be the accumulation of aqueous humor. It is continuously producing and accumulating in the eye but cannot move out because of the resistance in the trabeculum, right? So this will lead to the increased pressure. So it is later related to these structures of the angle. If there is any problem in the angle, intraocular pressure will be more, or there will be more pressure inside the eye. Now you should all know the normal range of the intraocular pressure, right? There are some certain readings of IOP. If the readings or the limits crossed, then it is actually the high IOP, and if the limit is below, and if it's not according to the range, or it is below the range, it will be the low IOP. So what is that range? It can be either 12 millimeter, in some cases it is considered as 12 millimeter of mercury, or the 16 millimeter. It can start either from, in some reference books, and in some places it's actually 12 to 21 millimeter of mercury, normal range of IOP, and in some cases it is actually 16 millimeter to 21 millimeter. So this is a normal range of the IOP. So there are, in normal person, there can be some fluctuations in the IOP. What are those fluctuations actually? So normal IOP, or IOP normally varies in normal person day to day or from time to time. At morning it is something, at the IOP is different, in the evening it is different, in the night it is different. So there are some changes of fluctuation, and those factors are basically the diurnal patterns. It means that at any time of the day it is different, and at different time it is, the IOP is different. So here you should know that in high, it is actually, the IOP is actually high in the morning. If you will check the patient's IOP, it is high, and in the evening when you will check the patient, same patient's IOP, it will be lower than the morning one. So these are the diurnal patterns which changes during the time of the day, right? Now next step, the next factor that can influence, or that can change IOP, is the blood pressure, right? So if there is any changes in the blood pressure, IOP may vary. Caffeine usage can actually increase the IOP. There can be any false reading of the IOP, that is, the patient is actually normal, there is no any high IOP changes, because we all know that high IOP can actually cause glaucoma. So there is no any glaucomatous changes in the patient's eye, but still what is happening over there, the IOP is high because patient is using or taking intake of, there is a lot of intake of caffeine, or he's taking coffee, tea very much frequently, and very oftenly he's using it. So next factor is postural variations. You all should know that in different positions, or the IOP is different, right? So intraocular pressure varies, and this is very important thing, that in different postures, if you are sitting, the IOP may vary. If you are in the supine position, so the IOP may vary. Now actually the important thing is that what is the classification of tonometry techniques, right? So tonometry is actually divided into two methods, which is direct method, right? You are directly measuring the IOP, and one is the indirect method. So the direct method is actually, what is you are doing here, you are actually measuring the IOP directly, right? So this involves a technique which is manometry. That technique which is based on the direct method is of calculating or measuring the IOP is manometry, and in indirect method, you are indirectly, you are not actually measuring the IOP directly, but by some an other method, or indirectly you are calculating or assuming the IOP, which is actually based on two further categories. One is applanation and one is indentation. These are the techniques which are used for the indirect method, and there are further classification, that indentation can be done by the short tonometer, and applanation technique is also further classified into the non-contact. There is no contact with the cornea, and you are measuring the IOP, and in contact there is a contact, you are touching the cornea and then calculating the IOP. So in non-contact there can be a pulse here, ear puff, Perkins, and ear puff is the non-contact technique. And here, yeah, here the in the contact technique, the Perkins and Goldman, they are based on the phenomena that you are going to touch, or you are in contact with the cornea. So this is a classification of tonometry technique. So we are going to discuss the the detail later, but right now it's a simple classification for your remembrance. Now there is another technique that we use for the estimation of IOP. This is done when you don't have any tonometer available, you don't have any instrument or specified instrument, so you use or estimate the intraocular pressure by the digital tonometry technique. So by its name you may be thinking there is any instrument or digital, you are measuring the IOP digitally, but it actually means that you are using the digits or you are using the fingers, right? So in digital tonometry you estimate the IOP, you don't have any instrument, you are just assuming or estimating that maybe there is some IOP is high, maybe the IOP is low, right? So this is just a method by which you assume that is IOP is high or low. You don't have any specified value over here, you are not calculating but you are estimating, right? So here you are estimating the IOP by just using your fingers, right? By using your finger pulp, and you are applying a pressure to the eye and you are just touching the eyelids. Here you can see the examiner is just touching, or the doctor or examiner is just touching the eyelid, right? And he's just estimating by his finger pulp, he is just touching the eyelids and applying a little bit pressure on the eye just in order to measure the IOP. So now what is the interpretations of digital tonometry? When you touch the eye and exert any pressure on the eyelid, it indents softly, it moves inward, the eyelid moves inwards very quickly or easily. It means that eye is soft, and the soft eye will actually tell you that there is a IOP in the patient's eye is low, right? If it is firm to touch, neither it is very when you are applying a pressure, neither it is having a lot of efforts for you to exert a pressure, right? And neither it is so much soft that the eye is moving inside very easily. So in that case the IOP of patient is actually normal. And when it is hard to touch, when you are actually when you are applying a pressure, the eye doesn't indent easily, right? And it's very hard for you to exert a pressure, so it means that high IOP, the eye is hard. And this is how you evaluate the IOP in these patients when you don't have any instrument and you are using a digital tonometry technique. This is just a rough estimation of IOP, and it is actually estimated, or you can have expertise in this technique when you have done a lot of patients and you have done a lot of practice. So right now this is all about tonometry. In my next video I am going to tell you the techniques in detail, which is the classification of the tonometry. So stay tuned and thank you so much.